Hi, Mr. Hopper.
Hiya.
Hi, nice to meet you. I'm Dr. McDonald. I've just been asked to come and discuss some of the findings during your admission before you go home. How much do you understand about what you've come into hospital for this time?
And I've had it a few times, so I know what it is.
Right. Okay. So you understand you had ketoacidosis.
Yep.
And you've got better from that. The other thing I'm not sure that you're aware of is that, as you know, we did a scan on your liver while you were here. And so one of the things I wanted to talk to you about specifically was that we were just investigating some of the results of the blood tests that we got back when you came in. We're happy from the diabetic ketoacidosis point of view. You've obviously recovered from that, but we did some tests that showed that your liver function tests were a bit abnormal. They're not wildly abnormal, and we're not worried your liver's going to stop working or anything like that. But they're certainly worth investigating further. And so far, results have shown no other cause than that, other than possibly too much fat on the liver. And that's really a sign that you're, probably in your case, it's probably related to the fact your sugar control is not very good. Is this something that you've discussed before with your doctors?
Yeah, time and time again.
Right. And I understand this is your third admission for DKA this year, is that?
It is, yeah. And I don't see it too much of a problem. I know what I'm doing. It's just a bit of a lapse. It's fine.
Okay. Tell me about when you've come in before with DKA. Have you? What do you think is? Obviously, one of the main problems is that you're not getting enough insulin. Yeah. Is there something that precipitates that? Do you think, or?
Well, I think it's just maybe a little bit too much alcohol one night or something like that. But I know it's only like 3 times I've been in, but all the other times that I drink alcohol, I'm fine. So I just need to know my limits, and I do. So.
All right. So every now and again you get a bit drunk and lose track of how much you're drinking. And, okay. One of the other tests we did was something that measures your overall sugar control from day to day, and that test shows that really the sugar control is not optimal. It's far from optimal. And so really, I suppose from our point of view, it's important you understand 2 things before you go home. One is that the DK episodes are potentially life-threatening. People die from this. If we catch it at a point where we can get your sugar under control and we can rehydrate you before your organs start failing, then usually you make a full recovery. But often it's the case that we can't do that. You get very dehydrated. One of the symptoms, as you probably know, is that it's very hard to think straight, and you may not get to hospital on time, or you may be in a situation where you can't, or on your own and you don't have friends around you. So people do die from DKAs. And so I think it's important. I don't know whether that's something you knew about. Or
yeah, I know what the risk is, and I've told all my friends that when I go out drinking with them that I've got this, and we don't usually drink too much. It's only once or twice drunk too much, and then I've had to be in here, and I get better, and I go out, and it's fine, and then I do better, and then one night it just happens again. So.
The second thing that we want to talk to you about is that not only is there this problem from day to day, this risk of very sudden deterioration, but over the long term, if your sugar control is not very good, there are a number of risks. Is that something we've discussed with you before?
Yeah, well, I've heard it all before, and to be honest, I'm just fed up of taking the insulin because it's just making me tired, it's making me feel fat, and I take it, okay, I do it, I just sometimes have a lapse, and that's just the problem I've got to live with, and I'm doing my best, sometimes I lapse.
Do you think you take it at the dose that...
Well, I think that you give me too much. I think the doctors prescribe too much because it just makes me feel really tired, and I think there's too much there.
Now when you say that, do you monitor your sugar levels after you've taken the insulin? And does it ever go low? Does it ever go less than...
No, but...
Than 4, for example?
No, but it just makes me feel crap, and I'm fed up of it.
Okay. All right. And have you discussed this with our nurse specialist before? Has she tried to alter the dose, change the formulation of insulin, try and find something that fits in with your...
No, I haven't, but she'll probably just say the same thing, won't she? So.
Okay. So I understand you've had several consultations like this before. I mean, I think it's important that you know that what those consequences are if your sugar levels remain uncontrolled. And just for my peace of mind, as long as I can make sure you've understood that. I mean, the main things we worry about in someone of your age is eye problems. So you can develop problems with the back of the eye, the retina, and that can lead to quite rapid deterioration of your vision. And there's no sign of that so far, which is good news, but that might be a problem that we develop in the near future. The other problems are related really to your to the blood vessels in your heart, so you can get heart disease from diabetes and long-term poor sugar control. You get problems with your kidneys, and your kidneys can fail. And we know now that for the first time, we've seen there's some evidence that one of your organs is suffering as a result of the poor sugar control. We think your liver's having difficulty storing energy and storing fat.
Yeah.
And that's often an indication that there are problems about to come elsewhere. So I think this time things are a bit different, because I think, I know you normally say you feel well and you feel okay and you don't have any symptoms, but this is a sign that really that's probably coming a bit sooner than we expected. And it's not really a case of keeping your sugar under control to stop problems in 20, 30 years' time. I think we've already got a problem. And I think it's important you know that. So what do you think, I mean, in an ideal world, I mean, I know you say you hate taking the insulin and you take it, and I understand you don't necessarily take it at the dose that you should or the times that you should, but why do you think that is?
I feel that I don't want to have to just keep on taking it, have to keep on organising my life around taking the insulin, and I'm just fed up of doing it. I've been doing it since I was 12, and I can't be bothered anymore. And I take it, and it just makes me feel crap. So why should I keep on taking it? I know what I feel, and I feel crap when I take it.
Okay.
And it just doesn't do what it's supposed to. I'm sure it's supposed to make me feel better, and it doesn't.
So you feel worse just after taking it than you do before, and it interferes with your life.
Yeah.
Okay.
Can't do the normal things. I have to restrict when I'm drinking.
Right.
I mean, only 3 times I've had excessive drinking, and then 3 times I end up in hospital.
Yeah. So, I mean, do you think that there's? I mean, I understand what you're saying about control, and I understand it's very difficult to have a condition where you have to regularly inject yourself. You have to monitor what's going on all the time, and it's very difficult to work that into your lifestyle, and it's very easy to feel that that's controlling what you can do from day to day. I understand that. What do you, what my worry is, I suppose, is that actually what's even more controlling and limiting on your life is the complications of diabetes. So if you develop problems with your vision, for example, I mean, there must be things you love doing where even just small amounts of visual impairment will make that very hard, and that can progress very, very quickly. I'm very worried about how, if in your late 20s, 30s, and so on, if you develop the problems with your heart, with your kidneys, and so on from diabetes and poor sugar control, and that's enormously limiting on your life in terms of the things you can do and how long you'll live. So I think it's a trade-off. I know you've had this diagnosis for a long time, and I know it's come at a time in your life where when you're very young, and perhaps that the control it's had over you is something you've naturally always resisted. But my worry is now that with this new finding about your liver being overloaded with fat and having abnormal liver function tests, that we're now moving into the territory where you're at risk of really being limited even more by the complications. It really boils down to whether or not you can take control of this and control the diabetes rather than let the consequences of the diabetes have further limitations. And that's what we're worried about. And in the short term, we're really worried about these episodes of decay you're having, because those you could lose your life with those.
Yeah.
Now, I know you've had this discussion before, and I know we've talked about probably you've talked with other doctors about insulin regimens and taking different, I'm sure you're aware there's long-acting, short-acting, medium-acting forms of insulin. Do you think it would be useful to have a longer consultation or a series of meetings with our nurse specialist. And that might not be something you found useful in the past, but I think not only can she help find a insulin regimen that fits in with your lifestyle better, that gives you fewer symptoms that you seem to be experiencing taking insulin, but she's also, our diabetes nurse specialist looked after a lot of patients who are, as you say, fed up with their insulin, who've had problems with that, who've had problems taking it at the time, and she can give you a lot of support in that respect, in terms of finding a way to get control of it. Do you think that would be something you'd find useful?
Yeah, I suppose so, yeah.
Okay. So, I mean, what we can do from here is before you go home, we can make sure you've got an appointment with our diabetes nurse specialist. And we'll make sure before you go home, hopefully she can come see you and arrange and look at your insulin regimen, look at how your blood sugars have been changing over the last day or so, and try and find some solution that you can work together is fine. But from our point of view, it's very important that you understand that the findings of our tests and what they mean. We're not particularly worried that this problem with the liver function tests will lead to your liver developing scarring or cirrhosis or failure in the very near future, but there is a risk of that in the long term.
Right.
So, but it's really more a case that it's a warning sign that other organs could start to be affected by your diabetes, so it's a bit of a wake-up call.
Okay.
Does that all make sense, or is there anything else you wanted to ask or clarify?
No, thank you.
Okay, so you're happy if we arrange an appointment and we can discuss this further with a specialist?
Yeah, I suppose so.
Okay.
If I can change the way that I have to take it, change the dosage.
Okay. Well, thanks very much.
Thank you.
So the instructions you've been given in this scenario is to discuss a diagnosis of non-alcoholic steatohepatitis with a patient who has poorly controlled diabetes. But in the information you're given, there's obviously a greater problem, which is they have had several life-threatening episodes of DKA, and they're at risk of short-term and long-term complications of poor sugar control. Discussions about compliance with treatment are very common in the PACES communication skills section. And I think in this case, at a baseline level, your candidate would be expected to convey the important information, explain the diagnosis of non-alcoholic steatohepatitis, explain that there's an acute or immediate risk to the patient's life whenever he has an episode of DKA, and explain and make sure they understand that there are long-term complications, microvascular and macrovascular, as a result of poor sugar control. The good candidate will go a bit further and try and explore the patient's reasons for non-compliance. In particular, in this case, it seemed he was having, he felt worse, was having symptoms after taking insulin, which couldn't be entirely explained by hypoglycemia, and this is quite commonly reported. But obviously there's a great deal of resistance to the diagnosis and resistance to the limitations that imposes on his life. And the challenge here is to try and convince him that the consequences of diabetes, if poorly controlled, will be even more limiting. Important in these scenarios not to envisage converting a patient in 10 minutes to becoming a completely compliant, accepting patient who then goes off and controls his sugars perfectly. That's extremely unlikely. So you have to have a strategy for how you're going to develop this further. And fortunately in diabetes, most people now have access to diabetes specialist nurses, and it's a highly acceptable strategy to say that you'll arrange a series of consultations or a future consultation with someone who has a lot of expertise in this area and has a lot of experience dealing with people who have difficulty taking their insulin or fitting it into their lives or have symptoms. And with a vast range of insulin regimens available, you can be quite optimistic that they can find something that a patient will find agreeable. So it's important to make sure you leave the consultation with a plan for future action.